Welcome to this explainer. Today, we're diving into a really profound, deeply personal medical dilemma, and we're going to use real clinical data to unpack it. When patients face esophageal cancer, they hit this difficult crossroads in treatment, a choice that can literally alter the entire course of their daily lives. So, we're going to lean on expert insights to decode the complex choice between traditional surgery and chemoradiotherapy. All right, let's just jump right in.
Here is a roadmap for today. We'll start with the treatment dilemma, then the core trade-off. From there, we'll dive into the salvage surgery reality and the endoscopic safety nets. Finally, we'll wrap up with the monitoring commitment and long-term survival. Basically, we're going to walk through the exact risks, the vital safety nets, and the long-term survival data so you can navigate this whole thing with absolute clarity.
Part 1. The treatment dilemma. Let's actually start with a specific real-world scenario from our source material. Imagine a patient, a woman in her 50s, facing a really tough choice after being diagnosed with esophageal cancer with lymph node metastasis. She desperately wanted to save her esophagus using chemoradiotherapy. But her surgeon, he strongly advised against it, really pushing her toward the surgical route. This pushback left her totally confused, asking, why is radiation often stigmatized or treated as an inferior option compared to surgery? Honestly, it's a super common frustration for patients who want to preserve their organs but feel pressured by surgical recommendations.
Part 2. The core trade-off.
To really answer her question, we have to look at the fundamental differences, the core medical philosophy, between these two highly effective approaches. Surgery gives you definitive certainty. The surgical team goes in and physically removes the tumor. It's out. But that comes at a massive physical cost, the permanent loss of normal stomach and esophagus function. On the flip side, chemoradiotherapy preserves the organ, which is an absolute game-changer for quality of life. But, and this is a big but, it relies entirely on how the cancer biologically reacts to the radiation and drugs. It's a wait-and-see approach, leaving this lingering question mark because, well, doctors just won't know if the cancer is completely gone until after the treatment and all the follow-up tests are done.
That brings us to Part 3, salvage surgery reality.
So what exactly happens if chemoradiotherapy doesn't completely wipe out the cancer on the first try? This right here is exactly why surgeons get cautious. It triggers the need for a backup plan, known in the medical world as salvage surgery. It's a highly specialized backup procedure to remove remaining or recurring cancer after that initial chemoradiotherapy has failed. But here's the thing. It is not just a standard surgery. It comes with some incredibly unique physiological challenges.
The clinical data highlights a major hurdle. As they put it, the tissue hardens and patients may be weakened from radiation, making the surgery more difficult. Because the patient's body has already been through intense radiation and chemo, their physical stamina is just significantly lower. Plus, the tissue surrounding the esophagus suffer from fibrosis, meaning they become hard and stiff. Imagine trying to navigate surgical instruments through hardened tissue. It's way more complex, and it significantly increases the surgical risk compared to just doing surgery right out of the gate.
But there is good news. The medical field is adapting to this exact risk. Historically, the mortality rate for salvage surgery was estimated at over 10%. That's a 1 in 10 risk, which was considered incredibly dangerous. However, thanks to huge medical advancements, better techniques, and really rigorous patient selection, the landscape has changed. Clinical trials, specifically the JCO-GO909 trial, proved that in highly experienced facilities, the mortality rate for salvage surgery has safely dropped to around 4%. So yeah, it absolutely still carries risks, for sure, but it's become a much, much safer safety net than it was in the past.
Section 4. Endoscopic safety nets.
Thankfully, a major, highly invasive salvage surgery isn't the only backup option if the cancer comes back. There's another path doctors look for first. If a recurrence is caught super early, like before it even causes symptoms like difficulty swallowing, and it's still really small, it can often be treated far less invasively using an endoscope. This means the doctor can remove the small lesion right from the inside of the esophagus, completely avoiding the heavy, physically draining burden of a major salvage surgery.
So how did doctors decide which backup plan to use? Well, it all comes down to a strict set of medical criteria. Endoscopy is always the preferred route, but the lesion has to be tiny and localized to the surface. If it's too advanced for the endoscope, then salvage surgery becomes necessary. But to even qualify for salvage surgery, there can be 0 distant metastases. The cancer cannot have spread to other distant parts of the body. And crucially, the patient has to have enough physical stamina left to survive a major operation after having already gone through prior treatments.
Section 5. The monitoring commitment.
To actually catch those recurrences early enough to use an endoscope, patients have to make a huge commitment. You don't just finish radiation and walk away. You have to commit to a rigorously strict monitoring schedule. The process starts with the first endoscopy just 4 to 6 weeks post-treatment. Then it's monthly endoscopies. Yes, every single month, until a complete response is confirmed twice in a row. Only then do doctors gradually space the checks out to 3 or 4 month intervals. If you skip ahead to 3-month intervals right away, you risk the recurrence growing too large for the endoscope, which pushes you straight into that higher-risk salvage surgery category.
What exactly are doctors looking for during these monthly checks? Well, they'll only declare a complete response when 3 very strict visual and cellular conditions are met. First, absolutely no visible tumor remains in the esophagus. Second, no radiation ulcers or erosions are present. The tissue has to look fully healed. And third, a negative biopsy indicating 0 malignant cells. You have to hit all 3 of those marks definitively, and again, twice in a row, before you can even begin to relax that monthly schedule.
And finally, Part 6, long-term survival.
Ultimately, what patients and their families care about the most is the bottom line, long-term survival. Let's look at what the clinical trial data actually tells us about survival rates for stage 1 patients. According to the JCOG 502 clinical trial, the 5-year survival rate for primary surgery is about 86%. For chemoradiotherapy, it's 85%. From a pure survival standpoint, over a 5-year period, these two methods are practically identical. They are virtually neck and neck.
However, and this is absolutely crucial to understand, there is a hidden cost here. While the overall survival rates are equal, roughly 20% of the patients who initially chose chemoradiotherapy eventually required that backup salvage surgery to achieve that 5-year survival outcome. So to put that into perspective, about 80% survived with their organ beautifully preserved, but 1 in 5 still had to face the major surgery they initially tried to avoid.
The data makes one thing crystal clear. Neither treatment is inherently inferior. It simply comes down to weighing 2 very different life paths. Are you willing to undergo rigorous monthly monitoring to potentially keep your esophagus, knowing there's a 20% chance you might need higher-risk surgery later on? Or do you prefer the immediate physical finality of surgery right from day 1, organ preservation or physical certainty? Which path aligns best with your life priorities? It is a profound question, and hopefully this breakdown of the clinical facts helps illuminate the path forward. Thanks for joining me on this explainer, and keep asking those big questions.